Thank you everyone for joining this evening. Today we're going to talk about the pulled elbow, otherwise known as the nursemaid's elbow. Okay, so let's go for it. Let me get us to go. There we go. Okay, so one of the definitions that I saw in the articles is basically the pulled elbow or the nursemaid's elbow is a radial head subluxation caused by a traction force on an extended and pronated arm. The radial head basically slips out from the annular ligament, and the ligament then gets trapped between the capitellum of the humerus and the radial head. If we can all remember our anatomy, the supinator muscle actually has some insertion onto the annular ligament. So as the ligament gets pulled proximally into the joint, it pulls the supinator muscle as well. So there's just some anatomy for us. On the left of the screen, we've got the elbow joint. We've got the humerus articulating with the radius and the ulna. And I don't know if you can see my mouse, hopefully the little annular ligament sitting over there over the radius. And then the picture on the right, we've got a normal elbow joint over there with the annular ligament encompassing the radial head. And then as that force is applied, we can see that the radial head is slipping out from the annular ligament, and the annular ligament is getting trapped on the far right-hand side in between the humerus and the radial head. So in terms of the cause, it's, like we said before, a sudden longitudinal traction force that's applied to the hand, and particularly when the elbow is extended and in a pronated position. It's usually in children, so when the caregiver is holding a child's hand, maybe they're walking along and suddenly the child trips, almost falls, and the caregiver suddenly pulls on the child's hand. Typically, it can also be when the caregiver picks up the child by one hand. And in infants, particularly, if they're lying on their arm and they suddenly want to turn over in bed, they actually apply a traction force to themselves on their own hand and can get a pulled elbow that way. In terms of the epidemiology, it's actually a very common condition. It makes me wonder if I've missed a few of them. Some of the articles said that up to 2/3 of upper extremity injuries in infants and preschool children actually had the diagnosis of a pulled elbow. It's very common between children between the ages of 1 and 4, and very rare after the age of 5. It's more common in females, and particularly happens on the child's left-hand side. The theory for this is that typically the caregiver will hold the child's hand with their right-hand dominant arm. So they'll be holding the child's left, and then therefore the left arm gets the pull. And the other theory is most children are right-handed, so they've got more muscle development on the right arm, and therefore the subluxation is less likely to occur. So those are the two theories for that. In terms of what the child will present with, there'll be a classic history of the child having the arm pulled, and the parent may have heard a click as the subluxation occurred. The child typically experiences a sudden pain. The pain can be in the elbow, wrist, or in the shoulder, and the child will refuse to move the arm after the subluxation has occurred. And typically they'll hold the arm in flexion and pronation kind of against their bodies. In terms of the examination, you may see normal elbow flexion and extension, but there will be pain and resistance as soon as you try and supinate the forearm. They may have some tenderness over the lateral aspect of the elbow, and some children actually have no tenderness at all, and typically with the pulled elbows, they don't have any bruising or swelling. So the diagnosis is a clinical one. They'll present with this typical history of the arm suddenly being pulled, maybe a click, and then the examination where the child no longer wants to move the arm, particularly into supination. In terms of imaging, you would only really do this if you are worried something is not quite right. This doesn't seem like a pulled elbow. So the warning things that would go off in your head is if the history is a bit unclear, the parents aren't quite sure what happened, or if there's significant trauma, maybe the child fell from a large height, And if you're worried for a fracture in terms of examination, there's a lot of bruising or swelling around the elbow. With all these factors, you'd be worried that this is more a fracture and not necessarily a pulled elbow. And then you would want to do your radiographs. Interestingly, they do describe that during the process of radiography, that the radiographer might actually sort of reduce the arm by turning it, and they might come back from x-rays with no pain, and you'll think that the problem just disappeared. Then some of the articles that I read, particularly the newer ones, they seem to be wanting to use ultrasound as a way of diagnosing pulled elbows. Better than radiographs, as then you're not exposing the child to radiation. It's a lot quicker than sending them to x-ray, them having to wait there for a report, etc. And ultrasound can also exclude any fractures before you try and reduce a pulled over, therefore preventing any complications of that. And the ultrasound is really nice as well if your mechanism is a bit unclear and you want to see, is this a pulled elbow? So what you may see on ultrasound, the articles that I read, they're still sort of trying to find definitive signs, but some of the things that they described is you may see an increased echo-negative area between the capitellum of the humerus and the radial head. Then remember our anatomy from the beginning, that supinator muscle is going to be pulled proximally into the joint space. So it actually looks like it's curling over the radial head, and they call this the J or the hook sign. And in some articles, they described that they couldn't actually see the annular ligament anymore in a pulled elbow on ultrasound. So just to show you some pictures, this is where you would place the ultrasound probe, so on the anterior aspect of the child's arm, slightly lateral, so that you can see the radial head articulating with the capitellum. And here's a nice picture. I hope you can see my cursor still. So picture A, you've got your annular ligament coming over here, the radial head, this is a normal elbow. Here, we've got the pulled elbow, so you can see actually part of the synovium being pulled into the joint space. So that was a sign that this is a pulled elbow. Then on this image, so this is the pulled elbow. Here's your supinator muscle, and it's curling over the radial head here. So it's quite proximal. And this is a reduced pulled elbow. So you can see now the edge of the supinator is sort of far back on top of the radial head. So that was quite a nice one. And this, very interestingly, is actually the proximal humerus. So we've got our growth plate sitting with the arrow. The star is the triceps muscle, and then the triangle is showing like a deviation in the cortex of the humerus. So this is actually a fracture. So it's very nice that we can see fractures on ultrasound. And if you were to see something like this, you wouldn't then reduce, you would send that child for an x-ray. And then this is a protocol that I saw in one of the articles. I just simplified it a little bit so that it was easier to see, but you can go to the references and look up the article if you want to. So basically they had a number of areas that they would ultrasound in a child with upper extremity pain, and particular points was the distal radius. Then they would look at the olecranon fossa, the proximal humerus, and then lastly the radial head and distal humerus. If there was any sign of fracture, they would immediately send that child for x-rays. If no fracture, then they would assume that it's a pulled elbow and they would perform a reduction. So something nice, maybe we could think about doing an ED, and quite a nice sort of idea. Then just differential diagnoses to think about if you do have a child with a painful elbow. Obviously your fractures or soft tissue contusions, it may be a septic arthritis, and then you can get a radial head dislocation, which the child can be born with, and then forearm synostosis. So that's when the ulna and the radius are actually fused together. Can be congenital, and it can also happen after trauma if they've had a fracture and the bones heal actually by fusing themselves together. And then your child would also have difficulty supinating and pronating the arm. So just think of those with a painful elbow as well. In terms of treatment, the aim is to reduce that radial head back into the annular ligament. So we can do closed and open. Closed, there's two techniques, which we'll talk about now. And then open is only really for like a chronic subluxation that can't be reduced using the closed techniques. This, according to the literature, hardly ever happens and it's quite a rare thing to do. And post-reduction, the child will actually begin to use the arm normally within about 15 minutes. So the first technique is the supination flexion technique. So what you would do is hold the elbow with one hand. You want the fingers just to palpate the radial head area, while the other hand holds the wrist. And then quickly and firmly, you want to supinate the child's forearm while moving the elbow into flexion. As you do that, you should feel or hear a click at the radial head area. And there's just a picture showing you what you would do. The hyperpronation technique, again, hold the elbow, let the fingers palpate the radial head, while the other hand holds the wrist, and then firmly and rapidly, you also want to move the whole arm into pronation, and you want to go as far as you can into pronation. Some of the articles suggested that this would be the easier technique, a little bit less painful as the child's already pronated and they prefer to go into pronation than the supination. There was also a video that I watched that said, don't mess around, don't hesitate. You want this movement to be quick and you want it to be quite firm. It will be a little bit uncomfortable for the child, but as soon as you've reduced that radial head, they'll be much better and then actually be fine. So I'm going to show you a video now. It's just a quick one, just to see how they reduce these elbows.
We have a series of videos on common practical procedures in the Children's Emergency Department, so I hope you enjoy.
In this video, we're going to show you how to reduce a pulled elbow. There are two widely recognised manoeuvres. In the first manoeuvre, stabilise the child's elbow with one hand, and with the other hand, grab their wrist and forearm and gently hyperpronate. It doesn't matter where you put the fingers and thumb of the hand stabilising the elbow. In the second manoeuvre, stabilise their elbow again and gently flex and supinate the forearm. Review the child in 30 minutes. If they've not started using the arm again properly, you might need to think of other differentials.
Okay, so I hope that was helpful. And I just wanted to talk about the different reduction techniques from the literature. There was actually a study done where they were checking how pediatricians reduced the pulled elbows, and they were basically trying to suggest that we don't need to refer these cases to orthopedics. We can do them ourselves. Pretty much anyone can do that because they're quite simple reduction techniques. And in some of the studies, they showed that success at first attempt was up to 87%, 91% with the supination flexion technique in one of the articles. And they said 70% of the time you will hear a little click. And if you failed the first one, the second attempt is slightly more successful if you use the hyperpronation technique. Only 2% of the children failed both methods and were then referred to orthopedics. In a 2017 Cochrane review, it was suggested that the hyperpronation may be more effective at the first attempt. It was a very slight difference, but there was a minor change. So if you get a pulled elbow, maybe try the hyperpronation technique and see how it goes. This is just a picture of a Cochrane review if you want to look it up, also in the references. So post-reduction, the children have really good prognosis, as you saw in the video. Typically within 30 minutes, they're back to using the arm as normal. They do say if neglected, these children can have some permanent functional disability of the elbow if you don't reduce it. And then some children, especially below 3 years, they may have recurrent subluxations. If you do reduce a child that's having a recurrent subluxation, they do suggest maybe putting a cast for them. they said for about a week. But if it's the first time you don't put a cast, you let them go about as normal after the reduction. And then just remember to educate your parents after the reduction, and we should actually be educating all our parents to try and prevent these pulled elbows. So as the pictures are showing, you'd want to avoid pulling abruptly on any child's hand or wrist, swinging the child by the hands or wrists, especially when they are below 4 years of age. And that's the pulled elbow. Thank you so much for joining, and let me know if there's any questions.
Thank you, Nicole. That was awesome. I love the fact that you showed us some videos, because it's so much better when people can see it visually. Can I ask a favor? Can you go back to the video, that slide, and show it one more time?
Okay, sure. Let me make it there.
We have a series of videos on common practical procedures in the Children's Emergency Department, so I hope you enjoy.
In this video, we're going to show you how to reduce a pulled elbow. There are two widely recognised manoeuvres. In the first manoeuvre, stabilise the child's elbow with one hand, and with the other hand, grab their wrist and forearm and gently hyperpronate. It doesn't matter where you put the fingers and thumb of the hand stabilising the elbow. In the second manoeuvre, stabilise their elbow again and gently flex and supinate the forearm. Review the child in 30 minutes. If they've not started using the arm again properly, you might need to think of other differentials.
Awesome. Thank you so much. Does anybody have any questions or any comments for Nicole? I think you're off the hook. I think it was sweet and to the point. Awesome.
Great.
Well done. Thank you so much.
Thanks.
Bye.
Bye.